Jai Shri Gurudev. Vidya dadati vinayam, vinayat yati patrata. Patratvat dhanamapnoti, dhanat dharma tatha sutam. Knowledge makes one humble. Humility begets worthiness. Worthiness creates wealth and enrichment. Enrichment leads to right conduct. Right conduct brings contentment. Welcome back to the platform of Vidya Sambhasha, a platform for the PhD scholars to churn the knowledge and to mold the minds. With knowledge, say what other wealth can pay, which neither thieves by stealth can take, or kinsmen make their prey, which lavish never waste away. Namaste and very good morning from the team MANTHANA, Sri Kalabhairaveshwara Swami Ayurvedic Medical College, Hospital and Research Center, Bengaluru. Myself, Dr. Sindhura, Assistant Professor, Department of Chikitsa, would like to welcome you all on the online platform MANTHANA, a series of national webinars exclusively for the PhD scholars, conducted by our institution, Sri Kalabhairaveshwara Swami Ayurvedic Medical College, Hospital and Research Center, Bengaluru, in association with Rajiv Gandhi University of Health Sciences, Karnataka, as a mark of Silver Jubilee celebration. On this online platform, I feel honored to welcome Dr. Muralidhar Sharma sir, fondly known as Acharya Shishita, Professor Emeritus, SDM College of Ayurveda, Udupi, a best surgeon, physician, and a vice teacher, to speak on the topic Avasthanusara Chikitsa in Prameha. Sir, Team MANTHANA wholeheartedly welcome you on this online platform. It gives me immense pleasure to welcome the inspiration, Dr. Kiran M. Gaur sir, Principal, Sri Kalabhairaveshwara Ayurvedic Medical College, Hospital and Research Center, who is the guiding force of the event. Welcome you, sir. I extend my warm welcome to all the directors, deans, principal, all the PhD guides and scholars across India to this event. I take the stage to request all the directors, deans, principal, all the PhD guides to share their PhD thesis title, year of submission, and other details as we are documenting national level PhD research database, which will be shared to all the PhD institutions across India. Now, I would like to invite Dr. Abdul Qadir sir, Professor and Guide, Department of PhD Studies in Chikitsa, Sri Kalabhairaveshwara Swami Ayurvedic Medical College, Hospital and Research Center, to welcome the gathering.
Good morning. Jai Shri Guru. I offer my salutation to His Holiness Padma Bhushana Parama Pujya Jagat Guru Sri Dr. Balaganath Mahaswamiji. I offer my humble pranams to His Holiness Parama Pujya Jagat Guru Sri Dr. Nirmalanath Mahaswamiji, and offer my sincere pranams to His Holiness Pujya Sri Swaminath Swamiji. Our institution, Sri Kalabhairaveshwara Swami Ayurvedic Medical College, Hospital and Research Center, Bangalore, functioning under Sri Aditya Shiksha Trust, was established in the year 1996-97 by His Holiness Padma Bhushana Parama Pujya Jagadguru Sri Dr. Balaganath Mahaswamiji. It's a matter of pride and honor to say to all that our institution has successfully completed 25 years of its service in spreading the knowledge of Ayurveda to undergraduates, postgraduates, and PhD scholars. In this regard, we are celebrating Silver Jubilee by conducting series of national webinar, MANTHANA, as well as Sneha Varadi, exclusive for PhD scholars all over the globe, because we are supposed to create awareness in PhD how much necessary in the today's scenario, and we should collect the database and make a event in the RUHS as well as Kalabhairaveshwara. I welcome wholeheartedly the great teacher for many students and eminent speaker, great orator and well-versed practitioner of Ayurveda, who is very popular among all of us, Dr. Muralidhar Sharma sir, because today is going to deliver his guest lecture and enlighten all the PhD scholars how supposed to think and how to go in the future. I welcome you wholeheartedly from institution as well as faculty of Ayurveda and RGHS. I wholeheartedly welcome all the eminent scholars, guides, deans, and the scientists of Ayurveda in this platform. And I welcome all the staff and faculty of Ayurveda of Kalabhairaveshwara Ayurveda Medical College, and PhD scholars, PhD scholars, and all the organizing committee members for this event. Thank you.
Thank you, sir. MANTHANA stage welcomes you for the knowledge exchange. It's my pleasure to invite Dr. Satish B.N. Sir, Professor, Department of Dravya Guna, to introduce speaker of today's webinar session, Dr. Muralidhar Sharma, sir.
Jai Shri Gurudev. I am very much blessed to introduce Dr. Muralidhar Sharma sir for today's webinar series MANTHANA. Dr. Muralidhar Sharma sir has completed his post-graduation in Shalyatantra from BHU Varanasi. He started his academic career as a lecturer from 1983 at SGM College of Ayurveda, Udupi, and worked in various capacities such as reader, professor, and head of the department in Shalyatantra. He served as a medical superintendent at SGM College of Ayurveda, Udupi and Hospital from 2014 to 2018. He has served as a member in several committees of Ayush and CCM as an expert member. He rendered his service with remarkable growth of Shalyatantra department and his clinical identity as Ayurvedic clinician with modern outlook. He has published more than 15 articles in various journals. He was a resource person for various workshops, conferences, and CMEs at state level, national level, and international level. Sir is a popular teacher, a good surgeon, and a well-known Ayurvedic practitioner. Sir has been awarded from National Sushruta Association as National Sushruta Personnel and Best Teacher Award from RGHS. Thank you, Madam.
Is a good surgeon is the one who knows how well to do the surgeries, and the best surgeon is the one who knows when not to do the surgeries. I repeat, the best surgeon is the one who knows when not to do the surgeries. Sir is very popular in treating many surgical cases medically. Sir is an ardent follower of Acharya Shushruta and Charaka and is very well known for his classical Ayurveda practice with minimum possible medicines. Today is our pleasure and pride to have such an eminent personality on this platform to enlighten us with his experience, knowledge, and wisdom. Without further ado, I would like to welcome Dr. Muralidhar Sharma sir to deliver the presentation. Meanwhile, I request all the scholars to post their questions in the chat box, which will be attended at the end of the session. Over to you, sir.
Thank you. Thank you all. I hope I'm audible.
Yes, sir. You're audible, sir.
All right, let me continue. Thank you for the introduction. Now, I'm giving the opportunity to share my experience with you. The topic, the way I would be dealing with would be my clinical experience, sharing my clinical experience about the Prameha and the approach to the management, the stage-wise management. So I'll direct it well into the topic as such. Now, Prameha, they are categorized into two in Sushruta, Charaka, as well as Vagbhata, as well as in the current system of medicine. Sushruta has categorized Prameha into two categories, Sahajaha, Apachyanimitascha. That's genetic and then the acquired. Whereas Charaka has mentioned the categories as Sthula Pramehi, Balavanihaikaha, Krishastateka Paidurbalascha. Krisha Pramehi and Sthula Pramehi are the category mentioned by Charaka. Vagbhata has categorized them into two categories where Dhatukshayajanya and Margavarajanya. Now, all these three categories are exactly the same. There is not much of a controversy. There is no need to go into a controversy like which is right, which is wrong. Rather, all of them suggest the same, like one category, which is where the patient would be losing weight, and the other is where the patient gains weight. Or one is Santarpana, Santarpanotha, where Santarpana itself is the major cause, and another, either there could be genetic or there could be some abnormality of the physiology as such. Contemporary system of medicine also categorizes diabetes mellitus too. Now, whether I would now give more stress on the diabetes mellitus among the Pramehas. The other Pramehas just we will have a casual look. So, because after all, in the currently the major problem related to the Prameha is about the diabetes mellitus. So, from that point of view, diabetes mellitus is mainly categorized into the two types, type 1, type 2, which I think everyone knows it. Now, let me come to directly to the topic, where the major triggering factors for the Prameha are: one is Santarpana. Santarpana is Snigdehi, Madhurehi, Guru Pichilehi, Navanehi, Navamadhyescha, etc. And still more specifically, Gaudikescha Annehi, Paistikehi. The sugar containing substances as well as Paistika, carbohydrates. Now, that's one. The other one reason is about the diet, where you take more food and certain qualities of the food which would be triggering the pathology. We now categorize them diabetogenic food as such. The other is Chesta Dveshi Diva Swapna Shayasana Sukherataha, a person who doesn't do physical exercise and tends to sleep more during the daytime, etc. Also, so majority of the Pramehas are triggered due to the Santarpana. Santarpana of two categories: one where there is a excess of diet intake and maybe certain specific variety of the diet which could be not triggering. The other is the physical inactivity as such. Of course, the same is mentioned in all the other texts also. Of course, Vagbhata has mentioned very specific sentence: Ekasthanasana asana ratihi shayanam te vidhivarjitam. A person who prefers to sit in a single position and doesn't do the exercise, and who tends to sleep. Those who tend to sleep during the class or maybe during the speech also. Now, type 1 and type 2 diabetes, of course, most of you already might have come across. Type 1 is supposed to be due to the deficiency of insulin, and the type 2 is due to the dietary intake factors acquired. Now, compared to the incidence of this type 1, compared to the global situation, India has lesser incidence of type 1 diabetes. Type 1 diabetes, and comparatively least incidence in southern India, whereas it's more in the developed countries beyond and then globally. So that's the global map of type 1 diabetes. Whereas the type 2 diabetes, India is considered to be the capital of type 2 diabetes. Now, this again is a global data. Global data, I am showing the data to highlight the issue. Incidence of the type 2 diabetes in India is a maximum compared to any part of the world. And that's why India is now considered as the capital of diabetes mellitus. So when we speak of diabetes mellitus in India in our context, main focus will be about the type 2 diabetes, whereas type 1, which is insulin dependent, I'm not saying that it's not important, but our focus mainly would be, and all my focus would be about the type 2 diabetes mellitus, because it's one of the burning problems which we are facing, and we are credited, India is credited or discredited as the diabetes capital. Now, there are certain of the important theories why it's so common in India and what are those factors. Now, I will not go into all the details. I will be just highlighting certain of the important issues which we should be aware of, and we should be able to present it properly. There are certain wrong perceptions, and those wrong perceptions need to be correctly mentioned. Like now, one of that kind of a perception, which is supposed to be the hypothesis why it's more common in India. So I'm not going into the other global situations. I'm just focusing on our context. The one of the major theory is there is a thrifty gene in India. Now, thrifty gene, or it's also named as famine gene. So I am interested in discussing this issue somewhat in detail, because there are certain wrong perceptions which need to be clarified, and we should be bold enough to say like what's the real truth as such. So from that point of view, I will be going into this issue in somewhat more detail. Now, thrifty genes are certain specific genes which are present in the body, and these are named as a famine genes because the idea, that hypothesis is that Indian people for generations didn't have sufficient food. They were starving. India was a country which had to starve because there were not much of resources earlier. But now, because they are now eating more, they have somewhat better food, they tend to eat more, and their genes are not capable of conditioning to this kind of a food sufficiency, and hence there is a tendency for the accumulation of the this fat in the body, results in overweight, and this consequence of the overweight, developing the overweight, results in resistance to insulin, and then it results in diabetes. This is the hypothesis as such. Okay, that hypothesis is fine, but there are certain issues which we have to put it into very clear-cut perspective. The clear-cut perspective, the issue is like India was a starving country, and India didn't have sufficient food. This is one of the issues. Of course, there are lots of controversies on thrifty genes, like whether it's really due to the starving of generations or famines which were there for generations together. And many times in some of the articles, now this I am just referring to some of those controversial articles, which those who are interested may have to read, I suggest them to read these articles of different viewpoints on this issue. And I would be trying to summarize the issue in the coming few slides about that part. But the point is, there are certain group of physicians who are suggesting and highlighting that point, that Indians are not meant to eat full stomach. They had to starve. They were suffering from famines and so on. And this is one of the Western theory which is downgrading India. But unfortunately, majority of our Indian physicians, they attribute to the same without really knowing the truth. And my purpose now is to try to put the perspective clearly, and then highlight where the theories have gone wrong. It's not only from my idea. There are many articles which have disproved this theory of the famine being the cause for the genes, but the other factors are important. Now, one of the controversial issues is the global nourishment is assessed by one specific index called as hunger index. This is what the WHO does by assessing these criteria, mainly the three criteria: child undernutrition, child mortality, and inadequate food supply. These are considered as major criteria to assess the status of any given country, and that is named as a hunger index. This is one of the measures, standard measures of assessing the status of food and food nourishment. Now, interestingly, the hunger index in India, so that those theories which say that there is an insufficiency of food in India and so on, the hunger index in India is reducing gradually year by year according to the statistics. And the index of diabetes, incidence of the diabetes mellitus is increasing correspondingly, rather in the reverse fashion. So hunger index is reducing, the nourishment of Indians is increasing, but correspondingly the diabetes is increasing. So this is one of the important controversial issue, like those who say that famine genes are meant for the diabetes, are the reason for the diabetes. These facts disprove that. But the real issue is, there is a difference in the genetic structure of the European phenotype and the Indian phenotype. Indian in the sense it's all the Eastern countries. It includes the Eastern countries like China and so on. The Indian phenotype, the physical dimensions, the body would be relatively thinner. So the core part of the body is relatively thinner. Now this diagram, that black portion represents the core part of the body, muscles, bones, and so on. The white portion corresponds to the fat mass. So lean mass and fat mass are represented by this diagram. And comparatively, the lean mass of the Indian phenotype, when I stress upon the word Indian phenotype, it's not only Indian, it's about all the Eastern countries too. The same is true, but our purpose now is about the Indian issue. So the fat mass is comparatively, proportionately more as such, naturally. This is a genetic structure. So an Indian child and a European child, physically the European child, the size will be more compared to the Indian child. This is what everyone is knowing. Of course, physically the European phenotype is more stronger, thicker, and so on. it's a genetic character, and that's exactly the gene factor asset. Now, when there is a accumulation of the fat due to consumption of the food, due to these genetic factors, those who have a thick fat genotype as Indians, comparatively, it's a thick fat genotype in the sense comparatively by nature, the fat its layer is thicker. In such conditions, the accumulation of fat occurs much faster than the others. So comparatively, now this is exactly when there is accumulation of the fat, the net gain of the fat, accumulation of the fat in the European phenotype would produce a lesser impact than the phenotype of the Indian origin, and this results in a elevated ratio of load to diabetes capacity, as it is increasing even slightly compared to the dietary factors, which may have increased the fat content in the European races, may have more aggravated or more presentable form of the fat accumulation, and that fat accumulation will produce all that metabolic load issue, and that's how the diabetes mellitus is produced. So Indian phenotype or genetic structure itself is responsible for the predisposition to the diabetes mellitus. Now, the obesity, if you look at the total body size and the body weight, comparatively, the Indian body average weight is lesser than the Western country. But shape of the body would be changing due to the different causes of the accumulation of the body, accumulation of the fat. Now, and this is about the shapes of the obesity. Obesity caused by food. The abdomen tends to be increased, the upper part of the body tends to be bulged. And this is exactly the shape of majority of our friends here compared to the shapes which you see in the Western countries. The abdominal girth is more asset. Now, this is one. And another shape of the obesity which we see more common is the sixth variety, the obesity from inactivity. These are the two types of the obesity seen in major numbers among Indians compared to the other forms of the obesity in other countries. Of course, I don't say that these other forms of obesity are not seen, but they are seen. Now, this is how the pattern of the accumulation of the fat would occur depending upon the different causes. Obesity due to the gluten factors, obesity due to metabolic activity, and obesity due to the venous circulation. These are the types of obesity. Compared to all these six types of the obese persons, what we see in larger number are number 1 and number 6. These are the major variety of the obesity which we see, and maybe everyone who is hearing this may just look at their shape through the mirror and then identify which is the category as such. Now, once the accumulation of the fat and then the metabolic activity, insulin resistance, which develops as such, may not present as diabetes in the beginning. It may have different sort of the repercussions, and particularly those who have a higher tendency, that genetic factors, these thrifty gene tendencies, the insulin resistance would result in one major issue is the PCOS, the polycystic ovarian syndrome. Incidence of polycystic ovarian disease also is significantly high in India, and it's almost now the percentage is increasing very rapidly. Almost every third lady in the younger age group of around 18 to 20, most of the college going girls, every third, almost 30%, more than 30% of them would have different degrees of PCOS. So this is one more serious burning problem. Compared to the statistics of the diabetes, the statistics of PCOS is increasing very significantly, and unfortunately this is affecting the younger generation, and now the PCOS seen is seen in females, whereas corresponding physiological changes also would occur in the males, but it may not be seen at that age as such, and it may result in different form of the metabolic syndromes, and that metabolic syndromes are, I am not identifying those metabolic syndromes which may not be presenting as diabetes mellitus directly, but even before the diabetes, established diabetes occurs, it may present with the abdominal obesity, chest pain or shortness of breath, exercise intolerance. Now, very few people can run a distance compared to others, like and rather they will be always preferring to have a rest, preferring to have a lesser activity as such, as Charaka has mentioned, like a person who tends to move, she tends to prefer to sit. A person who prefers to sit, who is sitting, prefers to sleep, and so on. So that's exactly the issue. Chest pain or shortness of breath is again one of the very common symptoms in younger group of our people as such. Then where the patient may have abnormalities of the skin growth, neuropathy, retinopathy, acanthosis nigricans, hirsutism, abnormal hair growth. Abnormal hair growth in females, it could be the hirsutism, like in younger other way, it could be the acanthosis nigricans, where the hairs may become brittle and the skin also may become brittle, so on. I would remind about the Pura Rupa of Prameha. Among the Prameha Pura Rupa, Nakha and Kesha Vikriti is mentioned in the Samhitas, and now this is exactly what the metabolic syndrome would be suggesting. But during this stage, the patient may not be, a person may not be diagnosed as diabetes mellitus. Whereas in the female sex, because the PCOD would be presented easily, that can be diagnosed easily. Whereas in males, it could be the part as such. To have a criteria, the AHA guidelines has given a typical standard guideline of making the identification of metabolic syndrome when any three of these 5 criteria are seen. That's if the fasting glucose is more than 100 milligram, blood pressure is more than 130 by 85, triglycerides are more than 150 milligram per 100 ml, HDL, that the particular high density lipid, is more than 40 milligram, and waist circumference is more than 102 centimeters. And if it is a and if you fill into any 3 of the 5 criteria, that has to be considered as the metabolic syndrome, which could be the precursor for the diabetes mellitus. Now, Prameha Pura Rupa mentioned by our Samhitas, they fit into this asset, and Sushruta has clearly mentioned, Kristani Ardhani Vagasmin Pura Rupani Manave Pravurtumutram Atyartham Pramehinam Adisheta. If any of these criteria are seen, now important, I mean, AHA says 3 of 5 criteria, if you say that metabolic syndrome. Sushruta has mentioned Kristani Ardhani Vayasmin Pura Rupani Manave. If you find either majority or half of the Pura Rupa seen, then you have to consider them as a Prameha. Of course, one precondition according to him is a Pravurtamutram Atyartham. Now, if you are not able to know, if you have some difficulty in making of these criteria, metabolic syndrome can be simply identified by the shape of the body, and usually the shapes are mentioned as apple-shaped and the pear-shaped obesities. This apple-shaped obesity and pear-shaped obesities, they are almost very much sure signs of the possible metabolic syndrome, and hence you can identify the patients who are prone for diabetes mellitus. And interestingly, if you take a survey of the Indian population, irrespective of the food habit, like whether vegetarian or non-vegetarian, you have more apples and pears than other fruits. That's the unfortunate thing like we have. Now, the diabetes incidence in India also is more or has some relationship with the economic status. If persons who are having higher end of the economy, rich people, the incidence is very high compared to the poor people. That's another very incidence. Economy, the status of economy, social economic status is another of the criteria which will have a significant impact on the diabetes incidence. And it also has another relationship which I have established. This relationship I have established. The total these restaurant services in India and their value, it's increasing as such. There is a significant relationship between the comparison of the column raising of these quick service restaurants, particularly those home service these services like your Swiggy, Zomato, and so on, where simply by pressing a button you get the food directly, and the junk food, the other consumption of the junk food, these are having a very direct relationship as such. another important data which we have to be now sensitive is WHO has categorized this physical activity globally, and this is the data which was published in 2016, and there is a predicted value of 2020. It was 2020 as such. The number of people who have lesser or insufficient physical activity. Now, sufficient physical activity recommended by WHO is a minimum of 30 minutes of regular physical activity, which can induce certain sweat in a person per 24 hours is considered as a standard physical activity. Now, number of people who have a physical activity lesser than that optimum in India is increasing remarkably, and that again is categorized into two categories: the insufficient and inactive. These insufficient, 30 to 42% of the people have insufficient physical activity. 14 to 25, they are inactive, where the physical activity is extremely low. Now, these are the important data. Of course, when Bhagavata has mentioned Ekasthanasana Ratihi, that's exactly the point. Indians now have a identity of Ekasthanasana Ratihi and Vidhivarjita Shayana. Now, that's about the data. Now, important is the point which I would like to highlight is those genes which are now responsible for the Indian phenotypes and our changing lifestyle, particularly changing lifestyle of reduced physical activity and overconsumption of the food. These are the real responsibility for India being categorized as diabetic capital, but it's not really, because the Indians are of feminine category. Of course, Indians naturally had a habit of consuming lesser than what others do. The basic philosophy of India is to have food to survive, not to live, or rather have food to live and not to live to eat food. This is Indian philosophy of our tradition, our value, traditional value, our traditional identity. Unfortunately, we have lost that. Now majority of us are on that category where we are targeting to live to eat. So everything which is available, we eat more, and that eating more accumulated in the body is as good as the black money which is accumulated. So that excess of the food accumulated would result in the insulin resistance and the diabetes mellitus would occur. That's exactly like the unaccounted black money, which will be the source for asset. But traditionally, our tradition and our traditional value is to respect the food as Brahma, or as well as we have a philosophy of eat to live, not live to eat. And it's a sort of share and spare culture. Our tradition would be, if you have food, you have to share with others essentially. Not sharing the food with others is considered as a sin. Selling the food is considered as a sin. This is our tradition says, which we have completely lost link of. That's our unfortunate thing. And those who say that India is to be a feminine country, and because of the feminine, the genes have changed. The Indian history is that it's not of a hunter and gatherer culture. Indian history or Indian culture is not for hunting and gathering. Rather, cultivation of the food brains were in vogue much earlier than any part of the world. History says that. And the concept of Annadana, Bhuri Bhojana, and Ishta Bhojana, these are the tradition of India. And as we pray to the food, like Annapurna, as such, the purpose of the food is Jnana Vairagya Siddhyartham. The food is consumed for our improvement of the knowledge, our capacity to enhance the knowledge, and capacity to have a viraga, or a disaffection or detached life as such. Of course, that's the Indian, that's about the genetic conditions of India. Now, something which is not directly related to the issue, but those now who have some disappointment about the issue, and which I am saying that the food and so on. And of course, Indian body is, the physique of Indian body is weak, so on. Something which is the other way. It's not directly related, it is an extrapolation. Don't feel bad about having a relatively thin body and more fat. Compared to the size of the different size of the organs of the body, the cranial capacity of Indians is the highest. East Asians, now East Asians, Indians, ours. Whereas the cranial, our body may be thinner, lesser, the cranial capacity and intelligent quotient, the emotional quotient, 6.95. So we are meant for intellectual work. Indian physique and Indian lifestyle is meant for intellectual activity, not for consumption and food and digestion and physical activity. So this that's the other way. Okay, that's not the important point. Now directly coming to the clinical aspects of the diabetes. Now my purpose of wasting this time on this issue, these two issues like the exercise and the diet and sensitizing our situation is not to waste time, but it's one of the sensitive issue which we need to be aware, particularly Ayurvedic people should be aware of, and we need to think of bringing back at least a part of our traditional values into the real life. Now, coming directly into the current situation of the diabetes patients. Now, I'm just giving you my clinical experience. The spectrum diabetic patients whom I see in my clinical practice, a fresh diagnosis, whom I have made the diagnosis roughly. Now, this percentage, it's a rough percentage. I'm not saying that it's very accurate, but it's somewhat the same pattern. You have almost a very few patients who come to Ayurvedic physician and where we make a fresh diagnosis when the patient has either visited for other complaints or casually identified, like when a patient has come for some surgery and it's a routine that we do the blood sugar test, and then if the patient is identified without any obvious clinical symptoms, that's one category. And the approach to the treatment will be different. Now, I will be trying to giving my strategy of dealing with these categories of the patients. Then there are few groups of the patients who are diagnosed as diabetes mellitus recently, but before opting for any other contemporary treatment, some may prefer Ayurvedic treatment, and some category of people they come to us from that point of view. And this is around 5%. Then patient who is already on medical management somewhere, they opt for either an Ayurvedic approach or supplementing Ayurvedic medicines. Like they are stabilized, they have a good control with the contemporary system of medicine, but they may prefer an Ayurvedic supplement or a Ayurvedic management, shifting work to Ayurvedic management. That comes another group of the people. A patients who have unsatisfactory glycemic control, even after taking any contemporary system of medicine, their blood sugar is not under control and they come for Ayurvedic treatment. That comes one category. This comes larger number. Now it's important. Now our strategy to the treatment will be depending upon these issues. Then there are another category of the patients, and rather majority of the patients whom I see in my clinical practice are patients who are diabetic and they are under better control, stabilized glycemic control. They are under modern medicine and their diabetes is controlled, but they have come for some treatment of other complications like accompanying disorders like hypertension, osteoarthritis, etc., or any other disease and the diabetes is not an issue. That constitutes a larger number of patients. Another larger number of patients will be again coming with the other diseases. At the same time, they also have unstable diabetes. They may be taking lots of medicines, and majority of the patients who come to Ayurvedic doctors are of that category where they will be taking some medicines for some other or some alternative medicines. Like I use the term alternate medicine for the contemporary system. They use the word alternative word for Ayurvedic system. Anyway, let us not get confused when I use the word alternate system. The other system, the people would be using those medicines and they come to Ayurvedic treatment for such issues. Then a good number of patients, they come for diabetic complications like gangrene, ulcers, and ketoacidosis, and so on. Among the diabetic complications, nephropathy, retinopathy, that constitutes one. Gangrene, another major category of the patients whom I see in my clinical practice. Ketoacidosis is lesser. Insulin dependent diabetes mellitus. Now, these are all about the type 2 diabetes. Real insulin dependent type 1 diabetes mellitus, hardly around 3%. Who prefer for Ayurvedic treatment. This is the spectrum of patients whom I see in my clinical practice. Of course, any other physician may have a varying spectrum, but the range of this spectrum may vary depending upon the social identity of the physician. But varieties of the patients will be of this category only. And when I deal with the patient, my approach will be to see that the patient is not put into any loss. Whatever the current benefits, current treatment has some benefits, advantages. That advantages should be maintained as such and should be gained. Patient should not be at a loss. And because of my affinity to my system, patient should not be put to loss. That's one philosophy. And then, of course, we always prefer to keep an identity. And hence, my approach will be different for each of the strategies, each of these categories. My first approach to the first category, where the patients are identified as hyperglycemics, my approach would be to confirm whether they really need a treatment or not. And usually, I won't start a treatment unless the patient is given an opportunity to modify diet and lifestyle. So I will be advising about the diet and lifestyle. Now, what are those advices? I will be trying to deal with that in the later part as such. And particularly more cautious if there is a family history. If the patient's family history, fathers or parents have diabetes, naturally chances of that patient would have a more genetic possibilities would be more. And usually I don't prescribe medicines in the beginning, be it for 1 or 2 months, and see whether the sugar profile comes or not, becomes normal or not. At times, if the patient still have certain conditions, you cannot just avoid the medicines. Patients may prefer, their patients demand for some medicines. Then I would be preferring Nisha Amalaki. Simple, only that much. Either Nisha Amalaki, which is available in the market as a yoga, or I would be advising them to prefer Haridra, Kshirapaka, and Amalaki consumption. Virechana is another choice. I would always prefer to have the Virechana. And the stress is given about the diet and the lifestyle. Take care in the diet, and the precaution, what's the diet, I will be discussing that part later. Specific medical intervention only if the response is not satisfactory even after 3 months. The exception will be if the patient has surgical conditions or if there are other acute medical conditions. Of course, this exception, we cannot do this, wait for 3 months. That we take up the approach of treating those conditions as early as possible. Now, the approach in a patient who has a fresh diagnosis, but patients who is visiting for other related complaints, related diabetic complaints. This is important. There are many conditions which are considered as a stigma of diabetes. The stigma of diabetes usually, as per our text, is Prabhuta Avilamutrata, and the contemporary system identified polyuria, polydipsia, polyphagia. Now, these are the characteristics, but there are certain unconventional stigma, very important clinically. Patients who present with the numbness, neuritis, patients who present with the balanitis, itching in the genital area, both melanitis or vaginitis, brachial neuralgia with the frozen shoulder approach presentation, patients who tend to develop tinnitus, having sleep disorders, sexual incompetence, you should be more cautious about possibility of an underlying diabetes. The patient might not have been diabetic earlier, so that's how I identify a patient coming with these symptoms. I will be very cautious. I will be investigating for the diabetes mellitus with the blood sugar profile or HbA1c, depending upon the conditions. As such, so these are the unconventional stigma where the patient may not have the classical signs of diabetes, like classical signs of diabetes and weight loss, classical signs of diabetes, polyuria, polydipsia. These are not there. In that condition, my approach would be I will not again immediately except in those conditions where the patient have a classical sign of diabetes. Even if the patient is diabetic, but the patient has a stigma of the diabetes signs, I would be preferring to keep the patient under observation with the diet and the lifestyle modification for a shorter duration of 1 month. So whereas if the patient doesn't have any other symptoms, it will be 3 months. And then if the treating those clinical symptoms, like if the patient has neuritis, I will be treating with the Ashwagandha, considering this as Vata Prakopa, balanitis or vaginitis with Gandhaka Rasayana, and so on, tinnitus with the usually Lagusul Sekarvati, Gandhaka Rasayana together, neuralgia, Ekangvira or Vishmuswati, depending upon the condition. And one important is Virechana in such patients is a game changer. It can produce a significant change in the outcome of both these stigma symptoms as well as the glucose profile as such. So diabetes profile can be modified. The one of the important issue is when you give virechana, that samsarjana krama has to be followed meticulously. Instant virechanas and shortcuts to the samsarjana krama would be more harmful in such conditions. Then my approach in those patients who are recently diagnosed and then opting for ayurvedic management would be, it's again very risky proposition. Patients who have already been diagnosed as diabetes elsewhere and they have the option of going for any other treatment as such, then my approach would be, I will be screening those patients for the allied complications like neuritis, vascular pathology, albuminuria, cardiovascular status, and so on. And then approach would be, if the patient, the complaint is only the persistent hyperglycemia and not much of other complications, my preference would be a Chandraprabha Arogyavardhini Avipattikara as such a prescription, common prescription. This is just to reduce the accumulation of the ama, and Medodhatu, the directly targeting the Medodhatu virechana. This is the approach to such first category patients. If the patient has a potential risk cases, like if there are some risks as such, neuritis and so on, I would be starting with Asanadik Vata. Asanadik Vata is the Asanadigana plus certain of the few drugs which are added in our institution, in SDM institution, a patent which is prepared in our laboratory. Arogyavardhini Chandraprabha and Jasadabhasma may be added depending upon the response of the patient. In general, the in such categories, the non-compliance and dropouts are more as such, because with our treatment like Asanadik Vata Chandraprabha, patients may have a tolerance to, or maybe have a patience to continue the treatment for 3 or 4 months. Then naturally, for some or other reasons, they opt for other treatment. Not that our treatment has not given the results, but that it could be like the patients may have may prefer more convenient treatment on the other side. So dropouts are more comparative to the other categories. Then if the patient is not having any other complications and the blood sugar is in a moderate level, the virechana is tried, but in such already diagnosed conditions, the virechana often may produce the results. At times, the results are not very consistent, whereas in a fresh diagnosed conditions, the results are more satisfactory. Then, if the patient is on already a medical management and satisfactory glycemic control, it's always, I would always discourage such patients from shifting over. Changeover is always discouraged, because if the patient is already in a satisfactory glycemic control, and as usual with Ayurvedic treatment, the patients may have something like a soda bottle spirit. Initially, they may prefer Ayurvedic treatment, but after a few days, they may be just bored and they think of other options. So this kind of shifting population is quite high. So generally, I discourage, and it's always advised not to shift over. But if the patients shifts over, of course, lifestyle modification is quite important, and the changeover should be always gradual. It's not that we stop those medicines immediately. The immediate, but treatment will be the same. Asanati, Chandraprabha, Arogyavardhini, or Jasadavasma, or Vangavasma, depending upon the condition. Withdrawal of the existing regimen is a very complex issue. And when the patient is on a multiple drug, I'll try to just highlight how to, what are some basic clues of modification or withdrawal of different categories of the contemporary anti-diabetic drugs, orals. Now, this is only the type 2 oral drugs. It's not about the insulin. Sulfonylureas, if the patient has GIT symptoms, then they can be withdrawn, or rather they need to be withdrawn. One of the major complications of the sulfonylureas are GIT symptoms. So most of the times it happens, like patients who are on sulfonylureas, they would have burning sensation, irregular appetite, and so on. In such conditions, naturally there is a need for withdrawal, and we can prefer to withdraw those drugs. Like if the patient has hepatic or renal or respiratory symptoms, the meglitinides, they have to be withdrawn, or they has to be withdrawn first. Patients with the weight gain, biguanides can be withdrawn, and particularly if the patient also has a renal involvement, biguanides have to be withdrawn. We need to shift over to the others. If the patient has a cardiac symptoms or cardiac edema, thiazolidines, they need to be withdrawn as such. Glucosidase inhibitors, if there is a hepatic involvement, any evidence of the hepatic involvement, they need to be withdrawn or they need to be modified. GIT involvement, again, if the patients are on the DPP-4 inhibitors like sitagliptin, which is these are more common now. The recent prescriptions, most of the current prescriptions, they are in these gliptin categories. DPP-4 inhibitors, they are the more commonly prescribed drugs, and they tend to produce GIT involvement. Often it's diarrhea, pain in abdomen, and they need to be withdrawn. So on. These are the basic ideas or basic preferences of withdrawal of the drug when the patient is on ayurvedic treatment. Success rate in such condition is it's very difficult to predict. Depends upon the status of the body of the patient and the duration also. Longer the duration of diabetes, success rate is lesser. Many a times we may have to continue the other alternate drugs to a certain extent with reduced doses or maybe modified prescriptions along with our drugs, ayurvedic prescriptions. It may not be possible to manage such patients completely with ayurvedic treatment alone in a good number of patients. Rarely a few of the patients we can withdraw them completely. Also, that's depending upon the patient's response. To predict is quite difficult. To predict that outcome in the beginning is quite difficult. Then the other condition, other category is patients who have unsatisfactory glycemic control opting for ayurvedic treatment. This is where we cannot have a choice like to say that you have to continue with that same treatment. So we have to submit ayurvedic treatment, and ayurvedic prescription, my prescription remains the same. Asanadi Chandraprabha, this is my prescription basic with the Vangabhasma or Jasadavasma depending upon the response. Usually Vangabhasma Jasadavasma is added. If the patient doesn't show satisfactory response in 1 or 2 months, then I will be adding that. Now, the strategy is to target is to prevent or postpone the complications. It's not that such patients can be cured. Patients who have an unsatisfactory glycemic control with the contemporary system of medicine, it's not possible to cure them as such, but the complications can be prevented or postponed. And definitely all our drugs can be prescribed along with the coexisting these other prescriptions, provided the modification of those drugs would be based upon, as I have discussed, like based upon the clinical symptoms as such. Of course, dropout rates in such conditions of that category also is quite high. Then the categories 5 and 6, stable and unstable glycemic control who have come for other accompanying disorders. Of course, any of our medicines can be prescribed depending upon the condition. Like a patient who comes for osteoarthritis, I will be prescribing glucose. If the patient has come for jara or so on, mrutyunjaya and so on. So almost every drug which we prescribe in other normal patients, they can be prescribed along with the coexisting prescription. So co-prescription of ayurvedic drugs doesn't produce any harmful effects. Then if the patient is in a stable condition, I would be preferring not to involve or not to meddle with the existing anti-diabetic regime. Whatever the patient is taking anti-diabetic regime, that would be continued as such. Along with that, I would be prescribing those medicines which are relevant to that particular condition. And another of the usual confusion is whether asavas or sugar-containing churnas can be prescribed or not. Definitely yes, they can be prescribed without producing any significant changes in the outcome. They can be prescribed easily, and I do prescribe regularly if the patient's condition remains. In general, duration of the treatment is expected to be more than a healthy patient, like a patient with osteoarthritis, having diabetes and having not diabetic. A non-diabetic osteoarthritis patient may respond earlier, duration of the treatment may be shorter, whereas a diabetic patient requires a prolonged treatment. So diabetes makes the issues more complicated. Then another category of the patients are diabetic complications, and among them one quite common, very common are the microalbuminuria. Microalbuminuria is more if the patient has diabetes mellitus as well as hypertension. If there is a hypertension along with that, then the microalbuminuria incidence is more. And microalbuminuria is supposed to be the precursor for the later renal damage. So patients can later come in any different stages of the renal pathology. It could be renal injury or renal failure even. It's easy to identify and prevent those complications if we have identified at early stage. And such patients, I will be treating them with the Chandraprabha Punarnamandura Amritarista. Is the same principle as that of the Sandra. Even Saptavarna Kvata can be prescribed as such. Then, if the patient has resulted in chronic renal disease or a renal failure, which I would consider as a madhumeha. Diabetes mellitus, I don't consider as a madhumeha. The word though popularly is used because madhumeha is the end stage disease as such. So again, I will not go into that controversy. Naming is not important. From my point of view, diabetes mellitus, particularly type 2 diabetes mellitus, is a Kafaja Prameha. Name anything can be given. Now, in a patient with the chronic renal disease or a failure conditions, the early identification is quite important, and the management of the hypertension is absolutely essential. So, to manage the hypertension, I would not have any hesitation to use any contemporary prescriptions if necessary, SOS. And it's also important to take care of the electrolyte status and the pH of the plasma. And only when the creatine level is less than 6 milligram, I would be preferring to prescribe our drug, and my usual prescription would be Asanadi Chandraprabha Punarnamandura. Even if the patient is on dialysis already, it can help to a certain extent by increasing the gap between the consequent dialysis. We may not be able to stop the dialysis completely. Incidence of such patients who have resulted in chronic renal disease due to diabetes mellitus is increasing, and in India, it's almost every year there is an addition of about 3.4 crore dialysis patients every year. So it is one of the burning problem and one of the major issue, and a good number of patients come with that. The other diabetic complications which we see quite commonly are the peripheral neuritis, and usually my prescription would be Ekangavira Ashwagandharista, as well as maybe if necessary Rajayapanbasi, considering this as a Vataja Vyadhi, usually a Dhatu Kshaitanya Vataja Vyadhi. Arteriopathy, I would be considering this as a Vata Rakta complications, and my prescription would be Kaishoro Gugulu Manjeshari Vata, Manjeshari Ksharabasi, along with the primary treatment for the diabetes. Microvascular complications, it's usually Arogyavardhini Manjeshari Vata. Retinopathy, Triphala Churna with the honey and ghee is the usual prescription. Patients who present with gangrene and ulcers, a large number of patients who come to us are of that category, where our identity, my identity is a conservative debridement. We may not go for amputation as frequently as others, and that's the real identity. Large number of people would identify Ayurvedic treatment as a treatment where the foot is conserved, and to a great extent, without any boasting, I say that I have a credit of saving large number of limbs. People have identified, society has identified. And the speciality of our treatment is Tripalakwat Parisheka, Japyantirela, Manjeshari Ksharavasti, along with the conventional anti-diabetic and antibiotic treatment if necessary. The purpose, the rationality of the developing these complications are the vascular complications and diabetic gangrene. These are again based upon our Ayurvedic principle only, and it's quite important to identify them as such. The Rasayaninam Dhurbalyat, not the reason why they occur in the lower limbs, very perfect reason is mentioned by Sushruta, where due to the Rasayaninam Dhurbalyat, vascular complications occurring in the lower limb, they tend to develop these complications in the younger age as such. Then another complication which we rarely see would be the ketoid cirrhosis. Ketoid cirrhosis is an acute complication where the Prameha can result in due to extreme complication of extreme involvement of Vata, and Atikarshitana produces the Asadhyan Prati Nasti Chinta. Sushruta says, Charaka says, Asadhyan Prati Nasti Chinta. You need not bother about them. Of course, the prognosis is difficult to predict, and with our Ayurvedic management alone, it's almost, I don't think that it may be possible to bring the patient out of crisis affect ketoid cirrhosis. So for the crisis management, you need to have correction of the fluid loss, intravenous fluids are necessary, correction of hyperglycemia with insulin is also necessary. I would not have hesitation to deal with these issues, and the correction of the acid-base balance, which may not be possible with the ayurvedic treatment alone. Only after the patient has come out of the crisis, I may prefer the ayurvedic treatment as such. Then the last point is about the insulin-dependent diabetes mellitus who are opting for ayurvedic management. Combining ayurvedic regimen can help in prevention of the complications, and it can help in reducing the dose of insulin. But it may not be possible to stop the insulin completely as such. That's the important thing. Rarely, insulin-dependent diabetes mellitus may be shifted over to oral hypoglycemics along with our prescriptions as such. That's the one. Now, the basic issue like what's the dietary and the lifestyle issues and certain controversies related to that. I think I have clarified how I approach with the medical management, and important in case of the diabetes mellitus is more than the medicines, it's about the diet and lifestyle issues. Among the diabetic, lifestyle and dietary issues, lots of complicated words are like the glycemic index, glycemic load, calorie value, nutrition value, low carbohydrate diet, and so on. There are, and then possible different categories of the diet, low carbohydrate, high protein diet. These are the different varieties of the issues which are present in the, rather presented as a fashion issue. So instead of going up to all those complicated issues, I will be dealing with certain basic confusions in the society, and how I have planned my strategy based upon the facts which are existing. There is one important is the glycemic index of any food substance. Glycemic index means the time taken for increasing the blood sugar level after consumption of that food is the glycemic index. And the glycemic index of different categories of the food are available in internet, and this really doesn't make a huge change. That glycemic index doesn't really produce a huge change in the total outcome as such. I'm not saying that it doesn't produce any change as such, but it's not the important. Important is the glycemic load. Glycemic load is the total quantity. A substance which has a higher glycemic index still can be taken safely if the quantity is lesser in a patient who has otherwise stabilized diabetes mellitus. The issue would be of importance if the patient already has a non-stabilized diabetes condition, and then there is a significant fluctuation of the sugar level, then a preference of a substance with the lower glycemic index could be preferred. So diet maybe to a certain extent. Now, as far as the glycemic index is concerned, among the society, very common complication, this confusion is whether a diabetic patient can take rice or should take wheat and so on. Very common problem, and most of the times patients would be having a notion that wheat is better than rice, but it's not really true. Rather, based upon our context as such, the wheat is more brahmana than the rice. Now, this is from our text only. The wheat is more brahmana. If you consider the glycemic index too, the glycemic index of the rice is lesser than that of the wheat, almost at the same rate. Rice, the glycemic index is 73, wheat is 74. So rather, the glycemic index of the wheat is slightly more, whereas the glycemic index of the millets, siridhanya, they are comparatively the least as such. So naturally, if the patient has a choice and can adjust these siridhanyas or the millets, they will have some advantage, definite advantage over both wheat or the rice. Now, as far as the rice and the wheat is concerned, again the nourishment value also and the total calorie load of the wheat is almost 7 times more than the rice. Ratio of the calorigenicity, the amount of the energy produced compared to rice is wheat is 7 times more than that of the rice. So as far as the calorie load is concerned, wheat definitely is not preferable compared to the rice. Then so my advice is, if the patient is having a habit of consuming the wheat like North Indians, I would advise them to continue their diet. If the person is a South Indian who prefers rice, I would advise them to continue. And by changing over from one to the other and suffering that quality of the life doesn't have a birth. So it's not whether it's a wheat or the rice which is important. Rather, it's about the total quantity of the food which is important. Now, Mediterranean diet is the general standard diet which is prescribed as a standard diet prescription globally. And this is WHO also has given. And that Mediterranean diet, which is a standard for the diabetes, the stress is given. This is the widest portion, the maximum. Be physically active, enjoy meals with others. So this is what the suggest says. Then a larger quantity of fruits, vegetables, etc., rice and other grains here. Fish and seafood lesser, poultry, eggs are lesser, sweets still lesser, meats the least, non-vegetarian flesh is the least. This is the universally accepted and universally suggested, highly acclaimed pattern of the diet advised to the patients. And of course, this can be definitely adopted where with the asset, and it has a very significant value. A vegetarian diet would have a definitely more value than the other and asset. Then the other issue is about fasting and diabetes asset. There are different patterns of the fasting. When I say the fasting, there are different patterns of the fasting. One is as we do as Ekadashi was once in 15 days or so on. Then there are others, water fasting, juice fasting, intermittent fasting, and then Ramzan fasting, where the people would have a comparative fast, partial fasting for about a month or so on. Now, I would say none of these are definitely extremely beneficial. The maximum would be, the beneficial would be calorie restriction, which is to be followed every day. It's not few days a week. Calorie restrictions to be followed every day. That would be the best of the advice. And next to that, a regular fasting once in 15 days or so on, some at regular intervals. It could be Ekadashi or so on. I don't say that it has to be Ekadashi only. These would be more beneficial than going into all other forms of the confusing issues. I would not recommend any of that to my patients. I would be advising the patients to have a calorie restriction every day. And maybe if they prefer, it could be a fasting at regular intervals, once in a week or so on. Or the most important and most valuable advice is matrashi sarokalam syat matrahi agnehi pravartika. So every time you take the food, the quantity has to be lesser and it should not go beyond, never have the full asset. So my advice is every time you take the food, reduce the intake by at least 10% and stop eating even before you have the satiety. That's exactly what Bhagavad has said as Gurunam Ardha Sauhityam Laghunam Natisiptada, and I would swear upon that part, the issue, like there cannot be any better suggestion, whatever that global now about the diet and exercise, particularly with the diet regulation. You have significant large number of books, papers, journals, and so on, but none of them would be as effective as the statement of Vagbada, where the two important Matrashi Sarvakalam Sayata, another is Guru Nam Adhasotyam Laghunam Nati Sutra. So from Ayurvedic people, we should proudly publicize these issues, give it to the message, give this message to the whole world, like what we have is really the best asset. And another important advice is Anena Ksheha Dvamsho Panena Ekam Prapurayat. Never have the food beyond 1/3 of the capacity of your stomach. 1/3 of the stomach only has to be filled with the solid food, and another 1/3 with the liquid, and it is 1/3 should always be kept empty. This is important. And if 2/4, half of the stomach should be full with the solid, 1/4 of the stomach should be filled with liquid, and the next 1/4 always should be empty. Never have the stomach full. This is the one asset. Then, as far as the lifestyle, now about the lifestyle and the diet, Sushruta has advised a fantastic prescription for particularly for the rich. If rich, because they have lots of food supply and they have the habit of consuming more, one of the advice given by Sushruta to reduce their food intake is add the churna, the dried powders of pieces of Ustra, Ashwa, Thara, Khara, Purisha, पुरीशचूर्णानि अस्मिन् दद्यात् अशनेषु. The dried pieces of this horse or donkey and so on, and they add to the food, very bad assets. And that's the how you can reduce the calorie intake. Adding the feces to the food is one of the means of reducing the calorie intake. This is suggested by Sushruta. Of course, casually, there are certain diets which are available in the market, products which are available in the market containing protein hydrolysates, partially digested proteins where the calorie content are reduced, lesser. And those protein hydrolysates, they are prepared by cutting open the intestines of pig, and that semi-digested food collected from that tube which is connected to the intestines of the pig. That's processed and prepared as a biscuit, very popular traded biscuits in that protein hydrolysate containing biscuits, which are the size of passion. They have the same, it may not be the purisha churna, but a semi-digested purisha acid. Or the other suggestion which is given by Sushruta for the, again, rich is Vyayama, Niyuddha, Krida, Jagara, Turaga, Patati, Charya. Go to the maybe war field and fight with others, or maybe something like a gym now. Now, those who have enough resources, they spend money on gym. Whereas poor persons, it could be the suggestion by Sushruta is Adanastva, Bandavaha, Padatrana, Atapatra Virahita, Vaikshashi, Gramikaratravasi, Muni Riva Sanyatatma. So, Yojana Shatam Adhikam Magacheta. A significant distance without any supports as such. That's exactly the suggestion which is mentioned by Sushruta for those. Rather, and another very, very important is Krishyat Satadam Itaram Khane Dwapupam. You may have to dig a well, or the most important is cultivate the food which you have to eat. Or Shila Unchavrutti Bhutva Brahmaratham Uddhareta. Shila Unchavrutti. You pick the grain which has fallen down on the floor and then eat. Don't have a store food. So that storage culture, cumulative culture has to be avoided. Do rigorous exercise. The best of the thing is cultivate the food which you are going to eat. This is the real message. Of course, it looks impractical in the present situation. People may not accept, but at least this message has to be interpreted properly. And what the WHO recommends is a somewhat diluted portions of the same, and that's achieve and maintain healthy body weight, be physically active, and at least 30 minutes of regular moderate intensity activity in most of the days. More activity is required for weight control. Eat a healthy diet, avoiding sugar and saturated fats intake, and avoid tobacco use. This is the WHO recommendation, and what we recommend from ayurvedic point of view is definitely much better than others. Then the other usual common questions like whether jaggery or sugar is better in diabetes mellitus or not. I would say from our textual point of view, Guda is supposed to be better than sugar, but practically not much of that. But the other important issue is about the artificial sweetness. One of the major issue is that most of the diabetic patients, they prefer artificial sweetness, or the artificial sweetness now have become a part of the lifestyle, and most of those your cold drinks, as aerated drinks which we consume in sophisticated bottles, they are the major contents. They have the major content of artificial sweetness, and the artificial sweetness market share is increasing very commonly, and they are the cause of diabetes. Artificial sweetness, one of the major adverse effect of the artificial sweetness is they are the cause of diabetes. So I would not advise any of my patients to take artificial sweetener as a support for the diabetes, and not even for the other healthy persons. Those food substances which contain artificial sweeteners, they are one of the causes, triggering factors for the diabetes. Now that's in brief about the diabetes mellitus. There are many. I am not dealing with all the issues. I have selected some of the areas which I considered important and wanted to sensitize our people as it. But because the topic given to me is about Prameha, it would not be justified if I don't refer to the Pramehas, but I will be as brief as possible. The different varieties of the Prameha can occur in different status of the body because of the variations in the dosha, dhatu, malaha, vishesha. Due to the different status of the body, there will be different pramehas, and I think there is no fun in repeating those names, udakameham, ikshvalikameha, and so on. But from the clinical point of view, only few are some significant. Sandrameha, I would consider them as a proteinuria. That proteinuria, again, it could be of any categories, tubular proteinuria, overflow, or glomerular acid. And among the proteinuria patients whom we see, if the patient has come in a younger age group, it could be congenital nephrosis, or it could be glomerulosclerosis. Diabetic nephropathy is more common seen in the middle age. And then as in the older age, it could be the neoplastic or amyloidosis as such. So proteinuria is not a single condition that you need to evaluate, and all these assessment has to be done. So it cannot be possible to give a simple standard treatment for the proteinuria condition. But in general, with very brief as such, patients of nephrotic syndrome which are present in younger age, my prescription will be Chandra-Prabha Mrityunjaya Amsarista. Saptavarna Kvata is, I would be usually prescribing in all such patients who have proteinuria, irrespective of the causes, and that produces somewhat better results. Though it may not be possible to cure. One of the important is if the patient is on already glucocorticoid treatment, is important to have the doses taper gradually, never go as such. Then the other pramehas, in brief, again, I will, because majority of those pramehas may not be seen clinically quite frequently, I will be just picking up a few of the patients. I consider Ikshimehas, diabetes mellitus, and the other conditions like, it's not that they are equivalent. These are the conditions which I would be just considering as the different varieties of the Prameha as such. I will not go beyond that. With this, let me conclude, because I have already superseded the time limit. And the most important points are diet and exercise has the most important pivotal role in evolution and course of the diabetes. Healthy lifestyle is the most dependable intervention to prevent the diabetes. There are many wrong perceptions about the diabetes, and in the management of the diabetes, it's most important to remove those wrong perceptions and have a correct approach than really going after the medicines. The medical treatment would be having a lesser role than the lifestyle modification. Of course, in type 1, medicine has a significant role, whereas type 2, the medicines have a lesser role. And I would consider diabetes mellitus as the most common variety of the Prameha, and ayurvedic management of diabetes mellitus helps in resolution of the disease as well as prevention of the complications. With this, thank you, and I hope there will be lots of controversial issues and questions. I expect some questions also. Thank you.
Knowledge is powerful. No, knowledge on its own is nothing, but the application of useful knowledge, now that is powerful. I wholeheartedly thank Dr. Muralidhar Sharma sir for the thought-provoking session on utility of treatment modalities in different stages of the Prameha. Now the session is open for discussion. I request all the scholars to drop their questions in the chat box. Shall we proceed with the questions, sir?
Yes, if there are questions, I will be trying to answer those questions.
Yes, sir. So the first question goes as, sir, Meha is a Adipala Pravritta Vyadhi as mentioned in Shushita. But we see it as a multifactorial disease, as we see the manifestation of.
Yes, there is a genetic tendency. And if there is no genetic tendency, the disease may not be occurring. So acquired factors, of course, are responsible for the disease, but if there is a genetic tendency, that is the major reason. So that's exactly what we have discussed. Like, so Adipala Pravritta is absolutely fine. I think there is not much of a controversy on that issue, right?
Yes, sir. So Xanthelasma is observed as coexisting with dyslipidemia. But we have seen few cases where Xanthelasma is seen in absence of dyslipidemia. What may be the cause, sir?
It can. See, Xanthelasma can occur even in the patients who do not have a dyslipidemia. I do agree. There could be the other causes like local irritation of the skin, the other nourishment, other factors related to nourishment. But majority of the patients with the dyslipidemia and metabolic syndromes, Xanthelasma is seen as the major signs there. So that's it. And it's true with any other symptoms and signs, like it's not necessary that one symptom is always seen in only one group of the condition. So you'll have plenty of other causes. So a patient has to be evaluated as case-specific conditions, right?
So, yes, sir. So what is the management protocol in such cases?
Management protocol will be depending upon the causes. So we have limited to metabolic syndrome disease conditions. In the metabolic syndrome conditions, the major portion is about the diet and lifestyle. Even in other conditions, the majority of the times there could be some hormonal changes. At times there could be hormonal changes. Patients with the endocrine pathologies also can present with those symptoms. And in such conditions, the treatment would be specific to that issue. So there you need to evaluate the patient, and that Xanthelasma may not be the most important factor. There could be the underlying serious issue, and that underlying serious issue needs to be managed.
Thank you, sir. Sir, Vata Rakta coexisting with Meha is said to be of poor prognosis as per classics. Please explain the management.
Yes, of course. It's true. Patients with the vascular insufficiency, I consider Vata Rakta as a vascular insufficiency. Patients who have that vascular insufficiency will always have a poor prognosis. Management is always difficult. And it's not only about Vata Rakta. Any other disease seen in a patient with diabetes mellitus would have comparatively poor prognosis. So treating any condition, if a patient is diabetic, we need to be extra careful. Right.
Thank you, sir. And the next question, whether Rasaushadhi can be indicated for longer duration? What is your opinion on this?
Anytime, of course, Rasaushadhis can be as safe as any other medicine. I have used the Rasaushadhis in patients for more than 35 years. My clinical experience is around 35 years. And there are patients who are consuming Rasaushadhi every day almost. And it's about the fear of the Rasaushadhis, it's only a problem of Ayurvedic doctors. It's not the other way. Patients do not have a complication if it is prepared properly. That's a precondition, is if it is prepared properly. The major problem with the Rasaushadhis is a rather a perverted approach of considering this Shodhana as pure, chemically pure. Shodhana is not chemically pure. Shodhana is adding organic impurities and making it bioassimilable. So there are certain pharmacies who shift to that kind of an approach, and they are dangerous. So those who follow the traditional method of preparation, Rasaushadhis are absolutely safe. So I can assure anyone that Rasaushadhis are as safe, or rather much more safer than any other medicine, without any hesitation, right? It's very clear-cut answer. There is no need to have any other if and but.
Thank you, sir. Thank you, sir. And the next question is, what are the scopes and limitations of Vamana and Asanadi Niruha Basti in Prameha?
Of course, Vamana, definitely Vamana can be indicated. I am not saying that it should not be, but usually I would be preferring Virechana than Vamana. Simple reason, Vamana is not as easily acceptable that of the Virechana. So that's more of clinical experience is with the Virechana. Then Basti with Asanadi Path I have never tried, so I don't have any experience on it. Maybe or may not be. Right.
Thank you, sir. Sir, could you please share the guidelines regarding the approach to Stula Pramehi and Krusha Pramehi with an elaboration on
all that whatever we have discussed about the major issues about the Stula Pramehi today. Krusha Pramehi is primarily the insulin dependent. So one of the characteristic sign of insulin dependent diabetes mellitus is a progressive weight loss. And hence, majority of the patients, they come under the category of insulin dependent diabetes. And in my clinical experience, once a patient has a insulin dependent diabetes mellitus, insulin is mandatory. Without insulin, managing with only our drugs may not be possible as far as my clinical experience is concerned. I will be limiting to my clinical experience, right?
Thank you, sir. Another question goes as, sir, in patients who are dependent on insulin or oral hypoglycemic drugs, should we stop the medications and insulin during Snehapana? If yes, how to manage sudden hypoglycemia? status.
I think I have clarified that issue from my clinical experience. I think I have clarified to the maximum extent. Like, if the purpose is treating other conditions in a patient of diabetes mellitus, better not to meddle with the diabetes medicine prescriptions. Without the meddling with the diabetes conditions, we have to manage. If your target is to manage the diabetes mellitus in an insulin-dependent condition, withdrawing of the insulin or withdrawing of other hypoglycemic drugs. Withdrawing of the hypoglycemic drugs also is a very sensitive issue. You need lots of clinical experience. Certain basic logic of withdrawal of those drugs, I think I have mentioned in detail of which of the drugs have to be withdrawn in which conditions to a certain extent. To go into a complete detail of that, I think it will be quite difficult. It may not be possible that issue in 1 hour or 2 hours. You need to have a thorough idea of the pharmacology of each of the drug, and then only we can go for withdrawal. But a general, simple, brief statement would be never allow the sugar level to hike. So fluctuations in the blood sugar level can be more harmful other way. So we have to ensure that the sugar level is maintained stable. That's the point. So we may reduce the doses, modify the doses as such. That would be the brief explanation. I think your question is answered properly.
Aprakabasma in Madhuri.
Yeah.
So
Yes.
I repeat the question. What are your views on Swarnamakshika Basma and Aprakabasma in Madhumeha?
See, that's true. Now, see, there are plenty of such yogas mentioned in the Prameha Chikitsa. My prescription and my clinical experience, I always limit to very few of the drugs. So I may not try everything. But Swarnapakshika and Abraka, I have given in patients with the other complications in diabetes mellitus, and it adds to the effects. I'm not prescribing Abraka or Swarnapakshika primarily for the treatment of diabetes. But a patient of diabetes mellitus presenting with other complications, I may prescribe them, and it doesn't have any adverse effect on diabetes management. Rather, it has some additional advantage in the management of diabetes mellitus. That's my clinical experience, right?
Thank you, sir. Which type of shari is ideal for diabetic patients?
Which type of chara? Repeat the question. Which type
Yes,
of?
sir. I repeat the question. Which type of shari is ideal for diabetic patients which are having less glycemic index?
Repeat that word, shabi.
Yes, sir. Which type of rice or which type of
Rice?
shari is
Okay. I think I have clarified that issue. Millets are the perfect standards, and among the other issues, rice also. The black or boiled rice is one which has comparatively lesser glycemic index. I think I can show you that slide where I have collected the data of different types of the rices also. This is a basmati rice. You have that the glycemic index of, I think you are able to see the screen. Are you able to see the screen or not? I hope you are able to see the screen.
Yes, sir. I cannot. Yes.
Rice, different rices. This is from the data which we have. The glycemic index of the different types of the rice. Basmati has a comparatively lesser index like 55, and white rice 73 plus 4. Parboiled rice is 60 as such. So this is about the different types of the rice. Then of course wheat, oats, and so on. Millets are the better because comparatively they have lesser glycemic index. So when it comes to a question of choice of different rices, it's only about that glycemic index which makes the difference in the choice. But from my point of view, again, as I have clarified already, glycemic index has a very less significant role in choice of the food. The most important is about the quantity of the food, total calorie value and the glycemic load, which are the more important than the glycemic index. So when a patient comes to me, I give a very little importance to that choice of the food substance. It's better to make the patient have a more comfortable lifestyle to be by continuing the same diet, same type of food substances to which he or she is already adjusted with, instead of going for some other food which will be punishment. So if the patient likes, okay, fine, you may give that. If the patient doesn't like, I would not give up on stress upon that part, but I will be stressing more upon the quantity, the frequency of the food intake, and the total calorie value, and then the exercise, right?
Thank you, sir. And the next question, is there any chance of becoming Satmya to Ayurvedic medicines and less effective when taken for the longer duration?
It's not that way. See, that question I think is a very controversial question, right? It's not that way, that our medicines will not produce Satmya in that way as such. So need not bother about that. It can produce the results, and rather it's the other way. The Satmya from Ayurvedic point of view, in general, it's not only about the Prameha. What I have seen is those patients who are on Ayurvedic treatment regularly and don't take any other medicines, they respond much better to Ayurvedic treatment. This is what I have observed. I have large number of patients who are dependent on only Ayurvedic treatment and they don't take any other medicines. For any other condition, one simple smaller dose of medicine would produce immediate effect in those patients. So Satmya, we need to consider not in the form of tolerance, rather it's more sensitivity. That's it. So I have a very clear view on that part, right? So I think I have answered that question effectively.
Thank you, sir. The next question was asked, in metabolic syndrome, there will be insulin resistance. How Ayurvedic medicine helps in such cases?
So we are not bothered about the insulin resistance. We are bothered about the healthy status of the patient, considering this as the MADHU, and for the MADHU, you need to manage with the lifestyle. So that person who tends to sleep or who has a lesser physical activity, that has to be avoided. The Santarpana, the effect of the Santarpana has to be reduced by Apatarpana Chikitsa. That's it.
Thank you, sir. And the next question is, how effective is Ayurvedic intervention in treating complications of diabetes like peripheral neuropathy?
I think I have already clarified that issue during the presentation. It's quite effective. Rather, most of those diabetic complications, the only solution is in Ayurvedic treatment. So most of the patients at one or other stage, they would end up in Ayurvedic clinic. Every diabetic patient would, before the lifestyle, before their lifetime, they would end up in Ayurvedic clinic at least once or twice in their lifetime, because the contemporary system doesn't have a satisfactory solution. So as far as I don't say that every complication can be completely cured, but definitely yes, Ayurvedic treatment would have a better solution to majority of the complications, except a few emergency complications like ketoacidosis. In majority of the chronic complications, we have a better edge than the other way. And I think that part I have tried to deal with to a certain extent, somewhat detail.
Thank you, sir. I once again thank Dr. Muralidhar Sharma, sir, for clearing the queries related to Avasthanusara Chikitsa information. I request all the directors, deans, principal, all the PhD guys to share the PhD thesis title, year of submission, and other details, as we are documenting the national level PhD research database, which will be shared to all the PhD institutions across India. Now, I would like to invite Dr. Vijay Lakshmi, Associate Professor, Department of Chikitsa, Sri Kalabhaireveshwara Swami Ayurvedic Medical College, Hospital and Research Center for vote of thanks.
Jai Shri Gurudev. Namaste to all. On behalf of our institution, it's my privilege to propose the vote of thanks on this occasion. My heart fills with lots of gratitude and respect for our distinguished guest speaker of the day, Dr. Muralidhara Sharma sir, for accepting our invitation and sparing his valuable time for us to grace this occasion, and also for enlightening us with his commendable talk on Madhumeha. Thank you, sir, for clearing the concepts and enhancing our understanding pertaining to Avasthanusara Chikitsa in Prameha. I take this opportunity to thank all the directors, principals, deans, and PhD guides for encouraging PhD scholars to attend this webinar. I wholeheartedly thank all the PhD guides and PhD scholars across the nation for attending the webinar and making it successful by your active participation. I'm running short of words to express my humble thanks to our principal, Dr. Kiran M. Gaut sir, for initiating this webinar series and for the constant support to conduct them. I would also like to thank all our faculty members, PhD guides, PhD scholars, and postgraduate scholars of SKAMC, H and RC for their support and cooperation. Last but not the least, I thank the MANTHANA organizing team for making this webinar a great success. Thank you.
Thank you all.
Thank you, madam. I request all of you to reconnect on 8th July at 10:30 a.m. for the webinar to listen to Dr. Gopi Krishnayam, Professor at HOD, Department of Prashastra and Vaishya Kalpana, SJG Ayurveda Medical College and PG Center, Koppal, on the topic Rasaushadhi in Madhumita. Good day. Sorry for the request you all to reconnect on 1st July 2021. Dr. Anup Thakkar sir, IPGT RA, Jamnagar, is speaking on the topic utility of Panchakarma in ritual medicine.